My journey started in 1992 when I went for a laparoscopic conference in Strasbourg. At that time, I hadn't really been back home for a long time. I met an African-American surgeon then. He worked in DC. And at dinner, we were talking. And he said, "Oh, you're a Nigerian." I said, "Yes." He said, "Oh, I've been to Nigeria before." I said, "Really?" He said, "Yes." He went to do some complex fistula work in Katsina, Zaria, and Kano. And I was so envious of him. I thought, look at me sitting here in England and just doing all this mundane stuff. And there's African Americans going to Nigeria to help my own people. At that time, I had just finished as a senior registrar. I was looking for a consultant's work. But I made a pledge to myself that if the opportunity arose, I will come back to Nigeria. But one of the things I then did was to start working. And by chance finding, I met a chap called, he's now Sir Eldred Parry. Eldred he was the first professor of medicine in Zaria and started the Ilorin Medical School and also the medical school in Kumasi. And some of you who are physicians here will know that the definitive textbook for tropical medicine was authored by Eldred Parry. So we started working together at THET to do basic, I coordinated the basic and emergency surgical skills training for all the medical officers in northern Ghana. And I did that for 10 years. It taught me a huge lesson about what the needs of our people were. And each time when I spent the month, having seen what humanity was like, I was quite intolerant of some of the mundane reasons given at our university teaching hospital about this or that, and you're thinking you should come to where I just been and see what life was. So that was my motivation for coming back. I was lucky because all of that work I did at that time was appreciated by the university, such that they actually gave me paid leave to go and do the work. So it didn't really surprise them when I said I was going to go to Nigeria for sabbatical for a year. That was in 2009. So we had to look for a replacement and all of that. So in 2010, I came for a year sabbatical. And after a year, I requested to extend the sabbatical for another year, and they graciously agreed. I had planned to go back in 2 years' time. I had employed 2 surgeons who were trained in Nigeria, and I was working with them such that when I left in 2 years, at least I will be able to pass some things down. But having been around the country and having engaged with my local colleagues, because the first thing I realized in Lagos, and I had taken this for granted, we had the North Trent Surgical Society. Before that, when I was a trainee in Manchester, we had the Manchester Surgical Society. So there was always a collaborative of surgeons to share ideas, to discuss difficult problems. And there was nothing like that in Lagos. And if anything, they were working against each other. And I thought, this can't be right. So I then started the Lagos Surgical Society at the time, which was completely hosted by Lagoon, because I felt there was a need to do that. But after the third or fourth hosting, it became obvious that this was a Lagoon thing, and I didn't want that. There are two major teaching hospitals in Lagos, so I wanted the surgeons to take ownership of this. I think that was my mistake, because the next meeting there was a strike, so it was cancelled. Then there was another meeting that didn't take place. So that kind of died a natural death. And it's very interesting, because 3 years later, when a colleague of mine who also returned said, Jimmy, we have to start a surgical society. I said, yeah, right. So that was that. Now, I think family support is also important when you're coming back. I was an early starter, so it helped that my children were a lot older. And usually when I also helped. After a while, I was on the board of THET, so I was doing a lot of fundraising for them. And the fundraising was, I have a talk that I usually give for about 50 or 60 minutes, which was called Gems from the Gold Coast, Surgical Training of Medical Officers in Africa, which usually was well received. And often my children will sit in the audience and see the reaction of the people in the audience to this guy who was held in high regard. But that's Dad. What do you mean? You know? So it was easy for me to sell the story, although it was still a challenge. And there is never a good time to say you're going to come back. Why? Because the opportunity that presents itself, and mine was a huge one, because I was approached by the founders of Hygeia to say, Baba Elebute was going to retire. He needed somebody to take the mantle of leadership and surgical moving. We had a plan then, which was called Surgery for the Future, to try and move Lagoon to the next level. There had been some investment from Satya Capital, which is run by Mo Ibrahim. And he also had a vision to say, let's start a diaspora program. So we actually had a strategy session in London, and Fola Laoye, some of you might know, is quite a visionary person, Prof. Elebute's daughter, who was leading Hygeia at the time. So let's start a Surgery for Future program, engage Nigerians in diaspora. So in 2009, we started coming and going. So we had 3 surgeons that were coming, 3 obstetricians and gynecologists. But we realized that coming and going program was not sustainable. And I think that's one of the points to appreciate, that if you actually want to help here and build systems, coming and going may sound exotic, may sound like a good idea. It might be an introduction, but it's not sustainable. And most of the people who have done it, and I can take my shirt off and you see the scars to prove that. So, but we started that, and the opportunity came, so I thought, I have to take this. But I spoke with my children and my wife, who I had to get an exit to come to Nigeria, as you know. And so that kind of worked well, because they bought into the idea, and it was difficult because I had to be shuttling quite a fair bit. But what clinched it for me was that they were here with me on holiday, and Bill Clinton was visiting Nigeria. And we were meant to go out to Ibadan. They wanted to go and see my old medical school and things like that. But American Embassy said I couldn't travel that weekend because Bill Clinton was around. And if he had a problem, we were on standby to look after him. And that just completely blew my kids' mind. That, what, Dad, what do you mean? Bill Clinton? You? I said, yes, me. You know, so... And it occurred to my eldest daughter, who said, but that wouldn't have happened in Sheffield. I said, yes, it wouldn't have happened in Sheffield. And that's the difference of me coming back home. Because the kind of respect I get, the kind of status I have, I was the chairman of the International Development Committee. I was the chairman of the International Development Committee of the Royal College of Surgeons in England. And on that committee, there was Lord Ribeiro, there was Sir this, Sir that, who would say, Mr. Chairman, sir, point of order and things like that. Yeah, but if I left that room, I was now just another jobbing Niger surgeon who is a diaspora, you know. But here it's different. You get to make a change, and you actually have the opportunity to also integrate. And the way to do that is to engage and involve yourself in things. I realized I'd have liked to work in a teaching hospital because my passion for training had always been since I was in medical school. But I knew the limitations, and I actually did dabble into going to teaching hospitals to train. But I was telling Dr. Shuemimo yesterday about some of the rather unsavory incidents that I had that sort of put me off doing that. So I then changed tacks to say, let me engage in a different way. So we formed the Laparoscopic Surgery Society of Nigeria, for which I'm the president. So that way I get to mentor and proctor surgeons all across the country on laparoscopic surgery. I'm on the board of the Society for Quality Healthcare in Nigeria, and I'm the chairman of the technical committee. We're currently working very hard, and that's been done pro bono, free of charge, to develop standards for accreditation of hospitals across the country, which we've applied E-Square accreditation for. So those are some of the ways in which you can also come back. Now, to be able to integrate, I think that it is not just enough for you to be a specialist in your field or a super specialist in your field. And I know that the way, particularly UK where I'm more familiar, training is becoming highly specialized. And we used to joke that very soon you will just have a left-sided breast surgeon who, if you have a right lump, no, I can't do it, so you have to go next door. Now, for such super specialists, it will be difficult to come and settle in Nigeria. Because when you come back to Nigeria as a specialist, you have to be an all-rounder. You have to be a surgeon, not just so I'm a laparoscopic and colorectal surgeon. So the first day I came and I had a clinic that said colorectal clinic. And there were 3 patients there all day. And in the general clinic, there were like 30 patients there. And the guys there were struggling. I thought, there's a problem here. So you have to be an all-rounder. You have to be a good administrator. Very, very important. And those skills are essential because people look up to you. A lot of things that you want to do, if you're not in charge, if you don't try to drive that, you find that things may not happen. And sadly, Nigerians have a way of, if you ask them a question, this is somebody in authority, they will case you to see what answer does this guy want. And that is the answer they will give you. So I'll give an example. Now, for those who do laparoscopic surgery, they know that carbon dioxide is what we use to blow up the tummy so that we can see what we're doing. And I walked into theater and said, do we have carbon dioxide full, cylinder full? And the first answer was yes, because that was the answer they expected. But you see, the person said it in the hope that once I've moved on, they will quickly go and check that the carbon dioxide was there. But they forgot, they were doing other things. So here I was having put the trocar, carbon dioxide, no carbon dioxide. So you also have to be a biomedical engineer. You have to be a nurse specialist. You have to be a dietitian. All of those things you have to learn, and I think it is important. The other thing that helped me was that Lagoon Hospitals were on a path to international accreditation at the time, so that a lot of things that did not happen in other hospitals in Nigeria had to happen at Lagoon because of our international accreditation. And I was immensely proud to be part of the team that got JCI accreditation, which was the first in sub-Saharan Africa by Lagoon in 2011. We have maintained the accreditation for 2 cycles now. And that is even more difficult than the first accreditation. And it is that experience that I'm now using to inform the technical committee of the SQHN so that we can help develop standards. They have to be, and what we're trying to do is develop standards for Nigerians by Nigerians. We're not adopting, but however, it's got to be it has to be acceptable internationally. So that is the challenge we have. And I could remember the first time we had a workshop, and one of the essential things is that you should have potable water. And people were arguing about whether or not that should be a standard in a healthcare facility. So those are some of the challenges that we have. There have been frustrations. And I think coming back, you need to appreciate that there will be what I call a latent period, particularly for those of us who are surgeons, because we need to have referrals for our skills to be used. So that when I came back, now, mind you, for the previous 5 years, I had been going across all the major teaching hospitals in Nigeria, teaching on colorectal anastomosis using staplers. And I had interfaced with everybody. They knew my skills. I had operated with them. I had done the difficult cases with them. But it was different then because I was coming and going and I wasn't a threat. So immediately I said, I open shop, I'm here now. Then all the referrals dried up. Then all you got were the really, really difficult, impossible cases. I said, Shebi, that guy is that surgeon, London surgeon. Oh yeah, now, let's see what he can do. And that was what then tended to happen. And for almost 6 to 9 months, I really wasn't doing what I wanted to do. And it was the sad thing was that I will then often be called to other hospitals to see people's relatives who had surgical disasters, whom, if they had just sent them the week or two earlier to me, those disasters would have been averted. Or more, even worse, are the disasters from St. Elsewhere, when they then say, there's that guy there, I think he can fix you. But often, it might be too late. I think that the other point is that certain simple things that makes life easy for a surgeon at times can be hard to get here because they're just not available. And that's because we don't have the critical mass of people who do the sort of things that I do to make it worthwhile for anybody to invest in bringing those things in. So that at times, so often when I travel, a suitcase will be for stoma bags, T-tubes, and all sorts of things that I know will make my life. I may not need them for a year, but when I need them, I really, really need them. So that's something to keep in mind. The recession in 2015 was a challenge. And in 2011, 12, 13, there was quite an exodus of Nigerians in diaspora who came back. Sadly, about 3/4 of them packed their bags and went back in 2015 because all of a sudden, in real terms, our income dropped by more than 50% with the devaluation in Naira. And I know there is a buzzword now about universal health care. There is a word missing in that. It should be universal quality health care. There's no point in health care being accessible and then you die of postpartum hemorrhage or you die of sepsis or you have the wrong thing done. So it's got to be universal quality health care. And I think that is the challenge that we have. The capacity of our teaching hospitals worries me. And I don't have a solution to the problem. I try to interface with a lot of people, but we don't have a structured way in trying to fix this. The leadership really needs to think about how we have a sustainable. If you go back to 70s and 80s, we had people who in the teaching hospitals were, European Champions League players, right? They were not 3rd division or 4th division league players in football. But we need to get back to that, where we have Champion League players in our teaching hospitals. And the only way we can do that is to support them, to invest in that, and also for the people themselves to be humble enough to know that the world has moved on and they have a lot of catching up to do. There is the issue of empathy. And one of the things we've done in the SQHN with the standards is that we are the first accreditation organization, once we get our accreditation, to include empathy as a standard in healthcare provision. Because at the moment, if you go to our public hospitals, one thing that is missing, one thing that is zero, is empathy. Competence of the diagnostic and interventional support is another problem we have. Again, for me, I'm a laparoscopic surgeon, general surgeon. So things like interventional radiology, somebody is bleeding to death from their colon. I need somebody who can identify the bleeding source and put a coil to stop that bleeder. So I don't have to operate on that patient. Because operating on them, the mortality is about 80 to 90%. But if I cannot operate on them, then their chances of survival are a lot higher. But currently, we don't really have things like that in a structured way. At least not that I will be prepared to submit myself to have that person do it, because that will be dabbling. There is virtually no support for our elderly. So care of the elderly is a huge gap. And just like in pediatrics, where children are not small adults, the elderly are not old, normal people. They have their own issues. I have a 92-year-old mother, and I know what I'm talking about. The other is the provision of community services in terms of non-acute secondary care, palliation, hospice care, good, reliable hospice care that we will be prepared to take our parents or our relatives to. It's just not there. And those are things that we really should address about how we do. Some of the things that have surprised me coming back home have been the fact that, in spite of all that I have said to you, there are some really, really excellent, hard-working doctors in Nigeria who are working against all odds. And the other phrase that I usually say is that the people with the worst attitude to health care in Nigeria are Nigerian doctors in diaspora. And I say that with experience. And so they believe that everything is bad. They believe that there is no good that can come out of the Nigerian healthcare. But if they were in the shoes of some of these people who were working, the other day somebody was denigrating the fact that a doctor was using a mobile phone light to put a drip up. At least he had his initiative enough to be able to find a source of putting the drip up. What do you want him to do? Say because there is no NEPA, you won't put the drip up? You understand me? So I think it's important that we appreciate that some of the doctors are actually trying their best under really, really difficult circumstances. And we should commend them. We should support them rather than denigrate them. I think I had talked about access to care. It's a bugbear of mine because, most people are one major health catastrophe from bankruptcy or death, or both. You become bankrupt and then still die at the end of it because of poor care. So all of those things are very important. And how do we ensure that people are covered when they're really, really sick? Insurance is the way forward. That's what most people have done. And we need to look at how we can ensure that our fellow Nigerians are properly covered in insurance. Sadly, the national health insurance is not national and it's not working. There are too few people that it covers. I think there are different figures, but I don't think it's more than 5% of the population. That's a waste of time. If you compare to places like Ghana and Rwanda that have a much higher coverage. Of course, you could argue that private health insurance is also the way forward. But of the 40 or 50 HMOs that we have, the lives that all of them cover is no more than 500,000. And their business model is flawed because rather than expand the market, rather than have 2, 3, 4, 5 million people enroll, so that you can have risk pooling, so that you can be able to share the benefits, what they are doing is competing for each other's market. There's just recycling those 500,000 people. And they are competing based on cost. So if you're to pay 5,000 naira premium and you include primary health care and just delivery, then I will come and say, okay, I'll do it for you for 4,500. I'll include cesarean section, including that. Another person will come, I can do it for 4,000. I'll even put there hypertension and this and that. But what they are doing is they are reducing the cost of healthcare on behalf of somebody else because they are not the providers. They are not the ones who will have to then pay the 500,000 naira to do cesarean section, do all of those things. So the poor providers, the only way they can survive is to cost. And if you do that in healthcare, quality will be affected. And if quality is affected, then lives will be lost. So at the moment, they are on a downward trajectory. That is my opinion. So they need to look at a different model. So currently, we don't have a way. So if you are an expert health insurance person in the diaspora, please, the market is huge for you.